Supriya, go ahead.
Yes, sir. We're live in 5, 4, 3, 2, 1.
Yeah. Good morning to everyone in India and good evening to everyone in USA. This is the first and the inaugural meeting with the Indian American shoulder and elbow surgeons. With this, I invite Dr. Paul Sethi to take over the proceedings.
Good morning and good evening to everybody. Thank you all for participating. We're really thrilled to create a collaboration between the Indian surgeons in the United States and the surgeons in India. For a long time, the group of us, myself, Anand, Murthi, and everyone who's on this phone call, Mandeep, Virk, and the team, Uma, we've always thought that, my gosh, we're from a place that has over 1 billion people and some of the most amazing surgeons. We've been amazed what the European surgeons have been able to contribute to the world of shoulder and elbow. In the times that I've been in India, I've been more amazed at the contributions and the things that I learned from my Indian colleagues. We thought that there'd be no better way to honor our heritage than to create an exchange of information that goes both ways, where we can really learn about the nuances of how things are getting treated in Asia and share and find the best practices between both countries. Because after all, I think there are so many things that we can learn from each other. We want to take further steps and engage in visiting fellowships. We want to be able to have surgeons from the United States go and learn from surgeons in India. And we want to have a visiting fellowship in the United States where you could spend perhaps 4 days in Baltimore and 4 days in Washington, D.C. and 4 days in New York City. And in my dream, 4 days in Connecticut, perhaps then at Butch's place in Dallas, and finally at Ranjan Gupta's place in L.A. And I think a visiting traveling fellowship designed specifically to engage the interests of the transcontinental surgeons is something that I've dreamed about for a long time, and we're ready to embark upon a release. So anyhow, enough of the theory. This is it. We're starting, and tonight we're going to talk about 3 different topics that we all see. The first one is capsulitis, and I'm excited to hear the Asian perspective. Then we're going to talk about instability, and finally fractures. And we're not going to just talk about reverses and latter J's only. We're going to talk about a lot of the regular problems. Instead of having one team present, we're going to have both teams present. And I'm really excited. I want everyone to engage in the chat. Shreyash has reminded me, and I have to remind myself to thank Shreyash for really making sure that I was able to organize this. You are a logistics superstar, much more than me. Your youth and your energy saved me here. But I want to encourage everyone to jump in the chat and really get involved and talk, because the more we talk, the more at least I'm going to learn, and that's my goal. On those opening preamble notes, I want to hand it over to our first honored speaker and someone who I've grown to admire and respect tremendously over the past few years. Shreyash, you are up first, I believe.
Okay, great. Thank you very much, Paul, for that kind introduction and giving this background, for having this association with you guys across in the US. Really, over the last 2 years since we started, it's been an excellent forum and a platform where we exchange ideas and learn from each other, and look forward to a much long-lasting and strong association with you guys. Welcome everyone from the Indian faculty side. I'm really very grateful for you guys to contribute, which is the core of this academic meeting, and also setting up a social platform for the future. So I'll just share my screen. Can you see it, guys?
Yes.
You see my
Yes,
screen? Okay, great. So thank you, Paul, Samir, and others from the group for asking me to talk on adhesive capsulitis, the Indian perspective. I work in Kokilaben Dhirubhai Ambani Hospital in Mumbai. So we all know that adhesive capsulitis is a very common yet debilitating problem. Unfortunately, over several years and decades, there still remains considerable uncertainty about its scientific literature and its clinical practice. And more confusing is that till today, we haven't reached to any kind of agreeable terminology. And we've referred to this problem as adhesive capsulitis, fibrotic capsulitis, primary idiopathic stiff shoulder, contracture of the shoulder, just to name a few. And this was way back in 1934 when Codman defined this condition. But obviously, there were a few things missing in the spectrum of the disease. And Tim Bunker from the UK in 2009 called it a condition which comes on slowly with pain over the deltoid insertion, inability to sleep, painful incomplete elevation and external rotation, the restriction of movement, importantly being both active and passive. Imaging is normal and the pain being very trying, and yet all patients are able to continue their daily habits and routines. Subsequently, in 2011, the American Shoulder and Elbow Surgeons consensus paper provided the following definition, which was agreeable to around 82% of the 190 member clinicians at that time. And they call frozen shoulder as a condition characterized by functional restriction of both active and passive shoulder movements, for which radiographs of the glenohumeral joint are essentially unremarkable, except for the possible presence of osteopenia or calcific tendonitis. Well, in 2015, the IASES Upper Extremity Council stated that the term frozen shoulder should only be applied to shoulder stiffness in the absence of an identifiable cause. And when stiffness is because of a known cause, they suggested that the term secondary shoulder stiffness rather than frozen shoulder be used. And they also suggested that from the available literature till date, adhesive capsulitis should be discarded because adhesions are no longer consistently observed in this sort of a problem. So you can imagine that we are still debating on the exact terminology and the definition. But nevertheless, as far as the incidence of this problem goes, it represents up to 5% of the population, more in males and females. There are certain comorbidities, and I'll come to a slide about it later. The peak age is between 40 to 60 years, and 20% of patients would develop similar symptoms on the contralateral side, and bilateral simultaneous involvement has been noted in up to 14% of patients in literature. So if you look at the IASES classification, they kind of call it a stiff shoulder and would term it as frozen shoulder only if idiopathic, whereas a secondary stiff shoulder would be related to various causes, be it intra-articular, capsular, extra-articular, or neurological. There are several comorbidities which have been seen in association with frozen shoulder condition, but importantly, hyperthyroidism, diabetes, which is of a very high incidence in India, and hence this condition is more prevalent. Cancer are three most common, which on multivariate analysis has shown to be a very high risk factor. And on the other hand, this type of analysis has shown that hypertension tends to be one of a protective factor against frozen shoulder. Looking at the pathoanatomy, predominantly it involves the rotator interval and the coracohumeral ligament. Thereafter, the glenohumeral capsule gets affected, and also to a lesser extent, there is adhesions or inflammation, synovitis around the biceps tendon sheath. On histology, in the early stages, inflammatory changes with synovial hyperplasia, subsynovial hypervascularity, and neurogenesis is seen. And in the latter stages, it is tissue fibrosis because of a high number of fibroblasts within the extracellular matrix of densely packed type 3 collagen, which becomes increasingly formed. This is a busy slide, but I think it is important to understand there is ongoing research regards the pathophysiology. But what we now know, it is that there's some sort of a trigger mechanism combined with the low-grade inflammation as seen in patients with diabetes, thyroid, or inflammatory disorders, which leads to an activation of the immune response. And that kind of causes the AGEs to initiate the pathway wherein the cytokines and growth factors, chiefly the tumor growth factor beta, is activated. And what that does is that it causes the differentiation and activation of fibroblasts to myofibroblasts. And this results in an imbalance of the extracellular matrix turnover and causes a contracture of the glenohumeral capsule with predominantly increase in collagen type 3. So this is, as per the current research, the pathophysiology postulated for this problem. Again, there are a lot of controversy regards the number of phases, but broadly speaking, we can look at it into 3 phases, although recent literature from the European side has even questioned whether we should refer to as different phases. But what remains consistent is that on exam, they have a global restriction of both active and passive range of motion, predominantly rotations as seen here. This is a patient of mine who's diabetic. And again, imaging is not important or never used predominantly in our diagnosis. Radiographs, as we know, unless it's a secondary cause, are normal. Imaging, if done, the positive findings would be the presence of a thickening of the coracohumeral ligament and the obliteration of the subcoracoid fat. And on the coronal view, one can see that the axillary pouch area is obliterated because of the adhesions. As far as the treatment goes, generally speaking, in the early phase, which is phase 1 and 2, conservative management does very well, and I will come and talk briefly about these shortly. And in the latter stages, where there's predominantly contracture leading to significant restriction in range of motion and patient function, some sort of a intervention can be contemplated. So if we look at conservative treatment, as far as the up-to-date literature goes, steroid injection has shown to be very effective for this one particular problem in the shoulder, but it's important that it is only beneficial in the early or the inflammatory phase. And if given in the latter phase, it is ineffective because it cannot reverse the fibrotic changes seen later in the cascade. Physical therapy, again, if tried in the early phase of the disease, really makes the pain worse, as we know that over-enthusiastic physiotherapy increases the patient's pain and discomfort. On the other hand, stretching exercises up to a tolerable level of pain has been shown to favor collagen remodeling and is also seen to be superior to supervised neglect, importantly in the stage later on in 2 and then in stage 3. Other modalities like extracorporeal shortwave therapy, calcitonin spray have been used with limited success. Again, hydrodilatation has been a modality. I had observed it during my training years in the UK. I'm not sure how often it's done in India, but it's generally carried on by an interventional radiologist who injects the capsule with saline and local anesthetic under pressure with an intention to disrupt it. It has to be done under fluoroscopy or USG guidance, and sometimes they use a radiopaque dye to ensure the accuracy of placement of the fluid. But again, the results are not too encouraging, and very little regards the success of this modality is available in literature. Manipulation under anesthesia was a type of intervention treatment, very popular up until the last 2 decades, where the intention is to stretch and tear the tight capsule. As we know, it's a very time-efficient procedure, very easy to perform, and results in a rapid restoration of range of motion. But importantly, the concerns of iatrogenic fracture, shoulder dislocation, traction injury to the brachial plexus, or damage to the cartilage and rotator cuff till date remains a concern, as confirmed on several studies scoping the shoulder joint after an initial MUA. So if conservative management fails, generally speaking, literature agrees that some sort of an intervention would be indicated following failure of non-operative treatment from 9 to 12 months since the onset of symptoms. IASES has given 5 particular indications. Number 1, failure of well-performed rehab for 6 months, failure of at least 3 injections in a 6-month interval, failure of less invasive treatment like joint distension or manipulation under anesthesia, severe frozen shoulder in diabetic patients in whom steroid treatment is contraindicated, and those patients who are significantly disabled functionally and wish to have a faster recovery. Now, arthroscopic capsular release has been the go-to procedure for most shoulder surgeons, and I'll just briefly talk about the principles. I do all my shoulders in beach chair. This is the left shoulder. Getting the scope in, getting an access is very challenging, as we know. The idea is to release the coracohumeral ligament and the rotator interval anteriorly, release the adhesions anterior to the subscapularis. There is a very well-defined plane which ensures that we don't violate the structures more anteriorly. and we have to reach laterally up to the biceps tendon to ensure that they've released the adhesions, and also go posterior to the subscapularis and also to the labrum as necessary. Certain incidental injuries like partial tears of the rotator cuff or slap lesions can be seen and can be debrided. And what I tend to do at the end of the anterior release, check the external range of motion compared to my EUA. I also most likely add posterior release, although certain studies don't. As you can see here, lower limit is up to the infraspinatus. I add it when there is restriction of internal rotation, even on EUA. Then after, I go subacromially, release the bursa thoroughly, and you can see that would ensure the overhead range of motion. At the end of this procedure, I also do a gentle MUA, and I'll talk the sequence of the MUA subsequently. So there have been certain modifications to this capsular release, a limited versus circumferential release. LaForce has also talked about a 360-degree capsular release, but my concern, at least in my hands, would be a risk of axillary nerve injury. And also, there are certain studies which do or do not recommend an additional post-release MUA. Now, when we talk about post-traumatic frozen shoulder, which is another group which we regularly see, the reasons could be a combination of extra-articular adhesions, direct injuries, or fibrosis to the capsular structures. And this is one such patient of mine who had this proximal humerus fracture fixation 18 months ago. And you can see his range of motion pre-op. He tried intense physiotherapy, steroid injections, it didn't work. His right shoulder is significant restriction in rotations. His forward flexion abduction were present 80%. So we did an arthroscopic release. Looking in the joint, this is the right shoulder. Significant adhesions. Again, it's important that we don't violate any normal structures. Anteriorly, there were a lot of adhesions, and same steps as what I highlighted earlier were carried out. Posteriorly, you note that because of this quite proximal fracture, he's developed changes in the glenohumeral joint, and a chondroplasty was done in association. So obviously, these patients would have guarded prognosis in terms of their recovery of function, but certainly the release would make a big difference. So I add a gentle MUA after the procedure. The first step is to forward elevate by 180 degrees, which would release the residual inferior adhesions as seen here. It's very important to have a short lever arm. Thereafter, the arm is adducted and externally rotated to thereafter release the anterior residual adhesions. Again, a short lever arm is important. Following that, the arm is cross-adducted, and this will release the posterior inferior residual adhesions. And thereafter, it is taken into 90 degrees of abduction. The assistant stabilizes the scapula downwards, and then external rotation to propagate the posterior inferior to the inferior release. And then the internal rotation is performed to complete the posterior release. So this is what I routinely perform at the end of my arthroscopic release. Post-op rehab remains very crucial, and we are all familiar with the program. Essentially, in the first 6 weeks, it involves stretching the capsule anteriorly, inferiorly, and posteriorly. There are various stretching exercises advocated as seen here, and subsequently strengthening exercises, both rotator cuff and scapula muscles is performed. So if we were to sum up in the interest of time, the current available evidence regarding the intervention, multi-center studies, this is a recent publication from the UK, Amar Ranjan and group. And what they have shown is that generally speaking, from the 11 RCTs that they looked at, physical therapy, steroid injection, MUA, and arthroscopic capsular release are all equal in terms of outcomes. There was not enough data available to draw any strong conclusions. Up to the surgeon to decide on which type of surgical intervention one needs to perform. In my practice, majority of these patients are diabetic and are managed with physical therapy for 6 to 9 months duration. Capsular release with the gentle MUA is only advised for those who fail non-operative treatment or those who are really disabled with significant restriction, predominantly in rotations. A lot of emphasis is placed on regular rehab because good surgery can, bad physiotherapy after good surgery can spoil results. And we've observed that diabetics really need to be counseled that they will take a longer time to recover and therefore need closer follow-up. So in summary, the current terminology of frozen shoulder is being kind of reinvented, and it's not referred as adhesive capsulitis. It remains a complex, multifactorial, and a poor understood process. Conservative treatment till date remains the mainstay, and so far there's no big difference versus between arthroscopic capsular release and an MUA, although the former is preferred because of the reduced risk of complications. Thank you very much for your attention.
Shreyash, thank you. That was awesome. I enjoyed every part of that, with the exception of the randomized study that says we have no idea what the right answer is. So without sort of going too far on that, we'll take questions after. But Mandeep, why don't you take over and clarify what's left unknown to us?
Absolutely. Thank you, Paul. Thank you, everybody, for having me here. So we'll get, it'll be a nice segue to Shreya's talk. We'll present cases both for, again, I see Shreya smiling because my title is Adhesive Capsulitis, which he strongly condemned and wants to be called frozen shoulder. So definitely we'll take care of that. So I have an esteemed panel with me, Dr. Prateek Gupta and Dr. Clement Joseph, who will be joining to go over the cases. So can everybody see my screen?
Yes, we can.
Okay. So first case is a 56-year-old left-handed dominant male, presenting with left shoulder pain and range of motion, limited range of motion for past 5 months. He's got severe pain, 8 to 10 out of 10, continuous, got component of night pain that is affecting his sleep, denies any trauma, nothing significant in his past medical or surgical history, and really has a desk job and loves to play baseball in a local league. So pertinent physical examination, this guy has severe limitation of range of motion. As you can see, the numbers out here, limited forward elevation, external rotation by the side and in abduction, and can reach to the sacrum behind his back. He's got real good rotator cuff strength, no other issues in history of physical examination. He's got these plain radiograph 3 views and Dr. Gupta, the first question is for you. So this patient is in your office. Walk us through how you approach this patient and how would you do any kind of further workup or the initial treatment for this gentleman?
So Mandeep, taking that I'm seeing this gentleman for the first time, and 56-year-old male with a typical history of pain gradually increasing the last few months with normal radiograph and limited motions, active as well as passive in all directions. Primary frozen shoulder is what my diagnosis would be, working diagnosis. And as usual, I would start with the non-surgical, that is conservative management, including initial non-steroidal anti-inflammatory local treatment and rehab. That would be my first goal, and review the gentleman in 2 to 3 weeks. As you said, there was no comorbidities, so I'm not worried, because in our situations, diabetes is very common. So I put always a lot of stress to inquire about diabetes, thyroid, and cardiac conditions. So he would go for his usual rehab, which would be, strengthening of rotator cuff periscapular muscle and stretching of the capsules, as Shreyash had just. That would be my first line, and review the gentleman in maybe 2 to 3 weeks to see where we're getting.
Dr. Joseph, would you do anything different in terms of, do you agree with the diagnosis component? Anything different in terms of lab testing? Do you actively seek to do any labs to prove that they have diabetes or any thyroid issues, or that does not affect your management? Dr. Joseph, are you here?
Let's keep going.
Yeah, Mandeep. As I said, we always inquire about those conditions, the systemic causes, and if there is a problem, then we obviously look for the latest reports. But if there's no history suggestive, then not in the first instance. That's my
And
take.
Dr. Joseph, do you routinely inject everybody with steroid, or is there any particular preference you have who should get injection versus who should not? And do you send everybody for supervised physical therapy versus home exercise program? Any preference or any difference?
Clement, you're on mute. Yeah,
Can you
please
hear
go
me?
on. Yes,
hear me?
perfect.
Yeah, sorry about it. I tend to assess these patients in terms of their activity level, whether the affected shoulder is dominant or non-dominant, whether they are able to carry out their normal activities, and if there is a sleep disturbance and overall irritability level of the shoulder. If this condition is very disturbing in terms of sleep and activity level and their daily life, I tend to advise them an early injection. Because in my opinion, the injections given properly can bring down the symptoms dramatically down. So my preference is I categorize these patients who are severely affected. They go for very early injections, of course, after ruling out all the diabetes and other things. Can you hear me now?
Yeah, we can hear you now.
Yeah, I tend to give a lot of injections, especially if the disease is severe. Then the injections are followed by physiotherapy. But if they don't respond in 4 to 6 months' time, probably I would consider doing an arthroscopic release.
Dr. Gupta, any preference for number of injections? Do you have any pet peeves for that in terms of, like, do you give 3 injections, 1 injection, or do you weigh in how patient is responding?
Yeah, I always weigh how patient is responding. And as I said, he'll go for rehab. And if he comes back with the same kind of problem and not settling down, severe pain, limiting his activities, and I've excluded any systemic cause, so because that also has a bearing on the treatment, then my next line would be to do, injection, cortisone-based injections. Now, generally we give 1 and I wait for the response. They go back to rehab. Generally, I wait for at least 2 to 3 months to see what's happening, because it is not that we get response within a week generally. So I tend to use a second injection after 2 to 3 months if the first one has had a partial response. And generally, third, I try avoiding. And if the person is not responding to the injection, then obviously to consider arthroscopic frozen shoulder release would be my. So that will be after 3 months of injection. If not showing any response, then I would weigh whether to give a second injection or surgical treatment. If there was a response from first, then yes, second injection would be there if it's partial response.
Dr. Joseph, do you have any protocol for your suprascapular nerve injections that you mentioned? Or again, you assess the severity and then determine? And is that something you do, or you have your intervention radiology folks help you with that?
Prateek, you can start.
Yeah, I use very often subacromial injection. I do it myself. Initially, I used to use and still use very often II control just to be sure. But very often now I do it in my office, a subacromial injection, which is then sprayed all over the subacromial space. And I've been quite happy with the response from that. Though I'm aware that many of our colleagues look at intra-articular injections. I had a look at the literature. It's equivocal, both sides, and people are still open whether it should be intra-articular or subacromial, but I tend to use more subacromial, and thankfully with good results.
It's very interesting that you make that point. You are spot on. Actually, if you look at literature, there's no difference between giving a subacromial versus a sub-intra-articular versus an intra-articular combined with subacromial, although the conventional teaching is that, it's an intra-articular process, you need to give an intra-articular injection. So moving on with the case, we touched upon, Dr. Shreyash also mentioned that it's purely a clinical diagnosis. We do not need any fancy imaging studies in order to prove a diagnosis. And as Dr. Gupta mentioned, like lab testing is not necessary, but taking a history asking about thyroid issues, diabetes issues, allow you to counsel the patient that they may have a more rough course or a longer course in terms of symptoms is important. So this guy, this gentleman, he got 2 steroid injections. One he got from a provider before seeing me. One he got from me. He did get supervised PT and home exercise program for good 3 months on anti-inflammatory medications, but his pain continues to be his biggest complaint, especially the nighttime symptoms, which are really affecting his sleep and then indirectly affecting his work. And again, not a surprise that there's minimal improvement in range of motion. So Dr. Gupta, this patient is in your office now back after 3 months of everything that you've tried. What will be your next game plan?
Yeah, Mandeep. So he's qualified now for thinking surgical intervention because he's had 2 steroid injections. He's had good rehab and is now over 3 months and not making any improvement, neither in the range of movement nor with the pain and his day-to-day activities. So he qualifies for surgical intervention. My thought process will start going in the terms of arthroscopic release. Though my personal experience has been over the period of time in last 10 years that reaching to this place has become much lesser in my practice, because when I started earlier, we used to do a lot of releases, and in last 1 to 2 years, it's been very, very minuscule. But at this stage, if he is not responding and taking the fact that he has had very good supervised physiotherapist work on him, then I would start thinking of capsular release.
And I assume that you're talking about arthroscopic capsular release. Is there any preference you have for beat chair versus lateral D-cube? And if that makes a difference in your practice?
No, I generally tend to do many of my shoulders in the lateral position, and I'm happy with that. And not necessarily I feel there's, in this particular case, it makes any difference whether it is a lateral position or a beat chair, because we are able to do equally good on both. So I don't have any particular preference.
Dr. Joseph, if this patient was in your office, do you prefer a surgical treatment, or there's something short of surgery that you like to try first?
Because in this patient, he failed 2 injections. I would definitely discuss surgical options with this patient. I prefer to do an arthroscopic capsule release in these patients, and I hardly ever done a manipulation anesthesia. I don't have that much experience, but probably I would discuss the pros and cons of these procedures, and I will lean towards doing an arthroscopic capsule release in this patient.
And do you prefer
options,
like
I'm not sure.
Capsule? Is your preference of a full capsular release, or do you prefer to do a limited, like Shreyash was showing, going posteriorly only if there's significant internal rotation deficits?
Yeah, I prefer to do a pan capsule release, but I'll tend to leave inferior centimeter of capsule in people who are less than 55 years of age, because I think unless you release a superior capsule and posterior superior capsule, these patients do not get the internal rotation, which has always been a problem for me. And people who are elderly, like above 65, I do a complete 360 release. But younger patients, to maintain some stability, I leave a bit of capsule inferiorly. So the superior and posterior superior capsule, I tend to release so as I can get an internal rotation post-operatively.
Dr. Gupta, what is your preference for dealing with the biceps? Do you normally take down the biceps every time, or do you, depending on the pathology, do you handle it differently in a young versus?
Yeah. We look at, once we have released, we look at the movement we have got, and then we get a chance to see what's biceps doing and look into the pulleys and area. And if it is not pathological, I tend to leave it alone. And especially in the younger age group, but in the older, like 60 or 55, 60 plus, if there is a significant bicep pathology, I tend to think of, tenotomy. But in my practice, again, I said we have reduced, so we do very seldom, but most of the time I've been able to save biceps. very rarely do I remember that we had to actually do an tenotomy.
Do you ever get advanced imaging prior to surgery? I know we talked about not getting it as a part of diagnosis, but prior to operating, do you ever consider getting an MRI or an ultrasound just for patient counseling, or?
Yes, it always, and in more than often, the patient, when he walks into office, he's already been to nooks and corners and he's already got all those things done. MRI has already been done by some of my colleagues. So definitely, and if I'm thinking of surgical intervention, I would like to do an MR. In our practice here, MR is more reliable than ultrasound. So we do that more often to see the areas involved. And as she has showed the thickening and how much is the obliteration and any other pathology, though X-ray has excluded anything else. But before doing a surgical procedure, I do an MRI. And as we said, if you're going to do a surgical procedure, just doing MUA, I do not feel confident with, and I'm confident with my surgical release of the capsules. I tend to do arthroscopic release. If I'm going to give GA and patient is going to come for this, I might as well do a good job properly under visualization.
Dr.
Mandeep,
Joseph.
you have a five-minute warning, Mandeep.
Sure. Sounds good. We've got 15 more minutes. Is that right, Paul? 10, 20?
I think 10:15.
10:15. All right. Let's, in the essence of time, we'll keep moving. So, as our panel faculty mentioned, this patient, because of severe pain and limitation of range of motion, I do the same thing. I do arthroscopic capsular release. I don't have much experience doing an MUA because I feel like if they are in the OR, I want to give them the best chance for maximum range of motion. So this is the guy after arthroscopic capsular release. You can see I don't do any manipulation after 360 release, and patients usually have nearly close to full range of motion. I do my surgeries in lateral DQ, but as Dr. Gupta mentioned, there isn't any evidence to demonstrate a beat chair versus lateral DQ position has any advantage over other. So this gentleman did well, pain relief, but again, none of the treatment options, whether do surgery or non-surgical, have shown to change the long-term natural history of the condition. So Dr. Gupta, in terms of post-operative protocol, any particular preference that you have for sling use in terms of rehab when you start?
Yeah, Mandeep, I think that is most critical in my thinking, because if you leave them for even a day or two, they tend to stick back and they start going backwards. So we generally use a scalene block, and sometimes we have the catheter there. And the patient in the post-op the same day has at least 2 full range of movements done, if not more, rehab. So we start the rehab the very same day in the, just post-op, and continue that for 1 day, because they generally after release they stay in hospital in our setup at least 24 hours, and we make sure that they continue moving and they go straight from there to the rehab department before even they leave, so that they're registered and continue with their rehab work, because that's most important. My feeling is, and my experience is, if you don't do that, they tend to stick back, and especially those who have that diabetes, they tend to fall back very, very quickly. So we start straight away.
I think it's a great point. Some people include of just making a video in the PACU, giving it to the patient so that they know what range of motion they have so that they can work on it. I'm just going to summarize before moving on to the next case, just adding on to what Shreyash discussed. A self-limiting condition, long protracted natural history, you should share with the patient, tell them that there are limited or no residual deficits in majority of patients. Purely a clinical diagnosis, no consensus on the ideal treatment, but we all agree that non-operative treatment should be the first workhorse for majority of patients. Operative treatment is less common, no consensus on the ideal treatment modality. None of the treatment options, surgical, have shown to be preferred or to be proven one above the other in any of the randomized controlled trials. So we'll move quickly on to the second case. Paul, stop me whenever you think that we are ready to stop. So next case is a 39-year-old right-hand dominant male, fell from a motorcycle, sustained the injury, which is shown down below in the x-rays. This gentleman got an internal fixation by me. He's 6 months out from surgery, has minimal to no pain, and you can see he's got severe limitation of range of motion. He's been doing supervised physical therapy since the time of surgery, but far out now, not able to do certain ADLs and leisure activities. Dr. Gupta, question for you. This patient walks into your office. You know, what's your algorithm to treat these kind of patients who are post-ORIF with not much in terms of malunion or abnormal alignment of the shoulder?
Yeah, Mandeep, he's a relatively younger gentleman, 39-year-old. Now, looking at the fact that he does not have any pain. Now, whether without pain do we classify him as a frozen shoulder, that's again a point of debate. But this is post-surgical procedure stiffness, possibly lack of rehab, or possibly the other causes. So I would like to first exclude anything else. And if I am convinced that the primary cause is stiffness in the shoulder secondary to procedure, I would again send him for a rehab. And if the rehab is not working, then obviously we'll have to think, because he does not have any pain. So giving cortisone, how much it is going to help, I am not sure. And if he's not opening with the rehab, I would start thinking about a capsular release or articular release in this case.
Dr. Joseph, any role for MUA early on for these patients in your practice, or anything different you would do for this guy who's 6 months out now?
I wouldn't do an MUA for this patient, because I'll be worried about the implants and creating a fracture as such. So I would do a similar approach like Dr. Gupta. But in this case, it looks more like an anterior soft tissue contracture, because he's got very less external rotation with the arm by the side. So we have to think in terms of a contracture of a rotator interval and a subscapularis. But when the arm is abducted, he's getting a relatively better external rotation. So in case if he doesn't respond to a supervised physiotherapy program, probably I would advise an arthroscopic release, mostly focusing on the anterior structures. But in these cases, post-traumatic cases, one should be ready to, even if you're not getting good range by arthroscopic capsule releases. Sometimes I have done subscapularis coronal lizardplasty also in extreme cases. So this would be my approach in this case.
Dr. Gupta, if you do take him to the OR, would you take his plate out?
No, I would not, because it does not look any of them being prominent, or any of the screw. The plate looks at a good position. So I would tend to leave it back, especially when I am going to put him through rigorous rehab. Another thing, my intention would be leave the plate there, just do minimal intervention. I don't want to do any more, because if I'm going to remove the plate, I'm going to make an approach. I'm going to make him fibrosed and stiff more later post-op. So I would do a minimal intervention arthroscopic procedure rather than going for plate removal.
So I dragged my feet on this guy, just like you guys mentioned. Eventually, he got an arthroscopic capsular release. Again, like Dr. Shreyash mentioned, compared to a post-traumatic or post-internal fixation versus an idiopathic, you'll see a lot of adhesions intra-articular, which won't be seen that much in an idiopathic. These guys have a lot of adhesions, a lot of scarring, especially in the region of the deltoid with the plate in the subacromial location, subcoracoid location. And, these are much more harder problem to treat and less rewarding compared to a primary idiopathic adhesive capsulitis or a frozen shoulder that undergoes a surgical treatment. So this guy did well. He's post-op 3 months out, improved external rotation and forward elevation, but his result is not the same like the guy I showed in the video, which was a primary frozen shoulder. So, take home point for post-surgical stiffness, that is the second most common that we see. It's a difficult problem to treat. Pathology is more extensive compared to the idiopathic variety in terms of intra-articular adhesions, subdeltoid, subacromial adhesions. Unlike the primary variant, outcomes are not self-limiting. It's not like if you leave them for 3 years that they're going to recover completely. Residual deficits are common, and depending upon who you are treating, they may or may not be acceptable to the patient. Again, no consensus on ideal treatment. Arthroscopic versus open release, a matter of preference. If you're taking the implant out, people have done arthroscopic as well, but open would be more amenable in that stage. I did not remove the plate on this guy for the reasons that Dr. Gupta mentioned. And then I just want to touch upon one thing. We do see a lot of these patients, like Dr. Gupta mentioned, they come with an MRI already loaded with a diagnosis of a slap tear or a partial bursal-sided tear, and they think that everything is related to those tears, and they want you to operate for them. But again, these findings are more just incidental finding rather than a true pathology. Dr. Gupta, before we leave and before Dr. Paul Sethi cuts me off, any experience on neurologic mediated shoulder stiffness?
Yeah, that's the systemic causes, like stroke or neuropathic shoulders, which we have because of distant pathology. I don't have too much of experience with that. It's not thankfully very common, but it is known, and these are difficult to treat. And we generally tend to err on the side of conservative than any surgical intervention in these cases.
All right,
Great.
Thank you very much, Paul. Back to you.
Thank you very much, Mandeep, Shreyash, team, Prateek, Dr. Joseph. I want to congratulate you all on having no conclusion and no definitive evidence to support anything we do. I'm rewarded. Next up is Dr. Sanjay Desai. Dr. Desai, he may not recall the first time I met him, but I was prepared to give a talk and a surgical demo on shoulder instability. And I had the fortune of him going before me. And in my mind, I had 5 important points to give. Well, during his lecture, he gave 7 important points, which encompassed all of mine. I had nothing to say. And since then, I follow what you write and what you tell me. So Sanjay, please take over and share your screen.
Thank you, Paul, and do forgive me for that. Thank you, IASES, for the opportunity, and I think it's a great initiative. Okay, is my screen visible to all?
Yes.
Yes.
So I've been asked to speak on arthroscopic Bankart repair, the errors, pitfalls, tips and tricks. I think most of you might agree that arthroscopic Bankart repair in the last 10 years has gone into disrepute, whereas everyone used to swear by this operation 10 years ago. Why? So first question I'm going to try and answer is Bankart repair the right choice? And to answer that, I ask a simple question. When the humeral head dislocates and sits in front of the glenoid, what structure is torn? And I think it's a very simple answer, which again, I hope every one of you will agree that it's the capsule labrum complex, which detaches or tears from the glenoid. Therefore, it makes logical sense that reattaching this torn capsule labrum complex seems to be the right operation. Do we have data to prove that it is the right operation? Of course we have. There's plenty of literature, particularly from the United States, which shows that it is the gold standard, the open Bankart repair. 26-year-old follow-up, 29-year-old follow-up. Most of you might be aware of this literature. So if open Bankart repair is so successful, then why is arthroscopic going into some amount of disrepute? I think to address the title of my topic, which is error number 1. The error is in understanding the pathologic anatomy. And the pitfalls are in the technique of repair. So let's introspect what we have been doing for the last, I have been doing for more than 20 years. And I will not hesitate to say that I have a series of more than 3,500 arthroscopic Bankart repairs. So let's introspect. Let's look at the pathologic anatomy. Forgive me, but I disagree with the bone loss cartel. I don't think it's all about bone loss. There's something more. Let's look at my small study of prospective study, 50 cases of instability, 50 control group, arthroscopy done in these 100 patients. And what we did is we compared the ligament laxity and the type of capsule with instability. How did we assess ligament laxity? We all know this, but I used only one criteria, the thumb touching the forearm. And this has been correlated with the 9 criteria that I showed earlier. So if the thumb is less than parallel, it's grade 1. If it is parallel to the forearm, it's grade 2. If it is almost touching the forearm, grade 3. And where it touches the forearm, it's grade 4. Has been established in 2020 by Cahill and group. So if you look at the ligament laxity in these 50 patients, 40% had moderate to severe, grade 3 or grade 4 ligament laxity. They had some amount of ligament laxity. So here is the data. What you see in the bar graph, in the instability group, 40% had a pathological capsule. What is pathological capsule? Grade 3 or grade 4. The thumb almost touching the forearm or actually touching the forearm. Whereas in the control group, only 2% had ligament laxity of grade 3 or grade 4, what I label it as pathological. It was statistically significant. Now, we also tried to quantify the capsule. I don't think many people have tried to do this. Look at this slide of 4 different instability patients. These are anterior band of inferior glenohumeral ligament. All are so different. This cannot be meaningless. This has to have some significance. And I tried to give some numbers to that. And I correlated the type of ligament with generalized ligament laxity. So how did we classify the type of capsule? If you have the anterior band of glenohumeral ligament 4 millimeter or less, that is type 3 or type 4, that's pathological capsule. Whereas if it is more than 4 millimeters and more than 8 millimeters, that is physiological capsule. So here is the same thing represented, grade 1, grade 2, which is more than 4 millimeters, and less than 4 are absent. And look at the number, 52% had what I call as pathological capsule, less than 4 millimeter, the thickest part of the anterior band of IGHL. And if you look at the same data in the control group, it is statistically significant. The yellow and the red is pathological capsule seen in 52%, whereas was seen only in 8% in the control group, the pathological capsule or anterior band less than 4 millimeters. And then if I correlate this with the generalized ligament laxity data, what it tells me is that as the ligament laxity, the generalized ligament laxity worsens, the quality of capsule drops. And this was statistically significant. Here is the graph showing that. And the instability repair failure rate correlates with pathological capsule. That means if I put a scope in, and if I find that the anterior band of IGHL is 4 millimeter or less, this patient has a high risk of failure of arthroscopic Bankart repair. If I summarize this data for a take-home message, about a third of your patients will have poor quality of capsule or collagen. It is constitutional. Now let's look at the pitfalls in the technique. Extremely important to arrange your OR. I do feel that the real technique of Bankart repair is slowly fading away, especially in Europe. When I visit there, I see that the youngsters have not seen that many arthroscopic Bankart repair because everybody is having lethargy and they are forgetting how to do it. Of course, we all do the 3-portal technique, but I must emphasize here that watch the whole operation from the antero-superior portal and not the posterior portal. I have seen, even in the United States, many people doing the arthroscopic Bankart repair with the scope in the viewing posterior portal. If you do that, you won't be able to see the capsule labrum complex and the neck of the glenoid as well. And you can't operate well if you can't see well. Let us remind ourselves what's the basic aim. Aim is to reconstruct the anatomy which has gone wrong, which means we want to reattach the capsule labrum complex well tensioned to its anatomic position. So some tips and tricks. Number one, extremely important, mobilize the capsule well. Unless and until you mobilize it well, it will not reduce to the anatomic level of the glenoid. It's like reducing a fracture. If you force the reduction, it is going to give way. So mobilize the capsule well. If I do this surgery for 40 minutes, I'll spend almost 18 to 20 minutes mobilizing the capsule. That important it is, because you want to pull up the antero-inferior slack in the capsule. Extremely important to curate the edge of the articular cartilage. I will tell you a few things about this in the next slide, but it's shown in a colored pattern here because it is extremely important. Use minimum 3 anchors. Remember, this is spot welding. So use 3 or 4 anchors, and you should have a 0 error in your knotting technique. You cannot have them loose over a period of time. So here is a curette, which is curating the anterior edge of the glenoid. Now, gentlemen, I ask a very simple question. Orthopedic surgeons have struggled to get the soft tissue to heal to bone for last decades. Example, tendo Achilles, rotator cuff, patellar tendon rupture. So how are we presuming that this soft tissue, the capsule labrum complex, is easily going to heal to the glenoid? I fail to understand. And it is even more interesting that there is no paper which proves that it has healed. This is the curate or don't curate prospective randomized control trial. You can look at Arthroscopy 2020, and there is a significant reduction in recurrence rate if you curate the anterior edge of glenoid, because I think it enhances the potential for healing of soft tissue to bone. So once again, I ask, what is the aim of Bankart repair? Aim is to make the capsule labrum complex heal to the anterior edge of glenoid. But where is the evidence? There is no evidence in literature. If there is, please show me. What is the incidence of significant glenoid bone loss in my series? Less than 10%. Therefore, how do I convince myself to do a Letarget in 40% or 50%, or in some places in France, 100% cases, do a Letarget? I do Letarget. I think it's a useful procedure in these kind of cases. My incidence is less than 10%. It's uncommon for me to do Letarget in more than 10% of my cases. Long-term results of arthroscopic Bankart repair, it varies from 4 to 35%, and it's worst in contact sports. Why? Let me try and address that. If this man on the left says that he wants to be a jockey, he cannot be. He is not designed by nature, by God, to become a jockey. He is constitutionally not suitable to be a jockey. Similarly, 30 to 40% of your unstable shoulders have collagen or capsule, which is not suitable for contact sports. Now, if these 30 to 40% want to do contact sports, and you may do a Letarget even without significant bone loss, as some people do, you will have to admit then that is a non-reconstructive procedure. It's a non-physiological procedure. The coracoid is going to disappear. And you'll have to confess that it's a non-anatomic salvage procedure. The take-home message, not so much the bone, it's the quality of collagen or the capsule, which is the main pathology, main culprit. Could be genetic. There is many papers which do hint at genetic being the cause. We have to find out, does the capsule heal to the glenoid by the techniques that we are so using as of now? The future, how to ensure that the soft tissue really heals to the glenoid, improve the biologics to enhance the healing process. And lastly, how to improve the quality of capsular collagen. Maybe like a cadaver kidney transplant or a liver transplant, we could transplant a patch of good quality capsule collagen into these unstable shoulders in the years to come. Thank you, and long live IASES.
Well, I've made the same mistake twice in life, and I would think I'd learn. I should never follow you in speech. This seems to be a terrible idea.
Thank you, Paul.
I'm going to share a few cases and hopefully not become embarrassed. Is my screen available?
Yes, Paul.
Great. So Nitin and Sundar, I think I have you guys up on the, and Sanjay, of course.
Hey, Paul, it's Anand. Are you embarrassed that you've only done 300?
You know, 3,500 is not quite the number I've gotten to yet. I'm embarrassed that I didn't know everything he told me about. All right. So look, I'm going to try and just go through a couple shoulder instability cases. And here we have an 18-year-old male. He plays two positions. So he's a shortstop, so a little like a bowler, and he's also a collision athlete. He's had a dislocation, and I treated him non-surgically. After one event, I said, look, you know, I don't know if you have to have surgery right away. I don't even think we got an MRI right away. He really wanted to continue with sport. And then I said, look, that's okay. So let's just go with a simple, quick question. And Sanjay, you start. Athlete, two sports, comes in, one event. Do you study him with MRI, and do you recommend surgery immediately on anybody?
Paul, a patient with your description that you have given, I will certainly offer primary arthroscopic stabilization procedure like a Bankart repair because he is too young. And my logic is very simple, very, very easy to justify. If I give you a modality of treatment for, say, malaria or tuberculosis, which has a failure rate of 90%, will you accept it? So we know that the failure of conservative treatment of a dislocating shoulder, one event in an 18-year-old involved in collision sports is more than 90%. So I will, of course, leave the choice to the patient, but it is very easy to explain to the patient whether he wants to accept a modality with a 90% failure rate. So yes, operate.
So anyhow, he's brought to the operating room after the second event. So the first event was non-surgical. And here's what happened. You're only getting a static view. You can only see the anterior inferior glenoid as opposed to what may have happened posterior. Sundar, let's be critical. What did the surgeon do well, and what did the surgeon not do that well? He did look through the anterior portal because he heard Sanjay Desai's lecture, so he's looking in the right place. But what else did he get right and wrong?
Maybe I think this view, what you are shown, looks a good lateral repair. Maybe they superiorly, maybe they had gone up to the subscapularis and tightened the little bit subscapularis, but I couldn't see any. Was there any Hill-Sachs lesion? Any remplissage was addressed? I'm not sure, but whatever the image, what you had shown looks to be okay. But I couldn't see the still anterior inferior margin of the glenoid because sometimes the extension can go beyond 7 o'clock position. So that's it.
Sundar, staying with you for just one more minute. Some authors in the United States have argued to put in, even when the tear doesn't extend beyond 6 o'clock, to put in a posterior inferior suture anchor or plication suture just to sort of stabilize the entire hammock. Do you subscribe to this? Do you not subscribe? Or what are your feelings?
Yeah, I do routinely post-lateral portal for my all capsular, labrocapsular repairs, anterior especially, because most of the time it goes up to the 6 o'clock position. Sometimes what happens that I try to elevate up to the 6 to 7 o'clock position too. So my posterolateral portal always helps to take the tissues from that 6 o'clock position to the 5 o'clock shifting will be easier for me. But at the same time, if it goes beyond 7 o'clock, yes, I do put that anchor through the posterolateral portal.
Anand, Murthi, any specific things you do differently in a bowler or a thrower? You know, we're gonna have overhead athletes in both continents. Do you do anything differently?
No, I do the same. Sorry.
Who do you got there, Paul?
Anand, Murthi, you overhead athlete, thrower. Is there anything you do differently?
I don't know if I do anything differently, but I think I've added more and more when patients who have instability added remplissage when doing arthroscopic, I think especially if they're off track, but even if they're on track, it acts like a check rein. And I think a lot of these failures of instability, even well done, labor repair, posterior inferior plication, if you add the remplissage, I think that's going to be an additional decrease in the recurrence rate. Be careful in a throw, or obviously you're may lose some external rotation.
So the plot will thicken, Nitin, so it's going to get harder when it comes to you right now. You're chilling in Goa, so we didn't give you any of the softballs. So at 6 months, he's back to playing baseball, and he says, gosh, something new happened. He has an MRI while he's away at school, and they say on the MRI, the Hill-Sachs is more pronounced, but the labrum is intact. When you're the primary surgeon, you of course deny everything to yourself. How is it possible that you'll get a bigger Hill-Sachs and have an intact labrum, right? So is anyone now on your own patient, not second opinion, on your own patient, because this is what you treat them differently, is anyone rushing back to the OR if he didn't fully dislocate, if he had a subluxation?
No. So basically, you would look at the initial MR and then compare to the present one, whether did you miss any Hill-Sachs in the first one, which was large enough, which required a remplissage. And you would like to compare that with the present MRI. What is the reason why his Hill-Sachs defect has increased in spite of having no true subluxations or dislocations? So the on-track, off-track theory is something which I use very routinely in the practice. And what I would also like to find out is if does he have any further subluxations now, or is it just...
Well, that's a good story. The first discussion I didn't have with him was Dr. Desai's discussion about telling him perhaps he didn't have the genetic makeup to continue sports. That one doesn't do that well for me in Connecticut. They storm out of my office mad at me. So you asked appropriately, Nitin. I'm going to give you a couple of details before I ask you to answer. Not only did he have more subluxations, he actually now comes into the office and shows you what had happened one time when he went to the emergency room. So you can't tell him he's subluxed. He actually was dislocated. So he calls the office and I have my nurse tell him I was out of town and I can't speak anymore. He said now he feels loose with ADLs. He's had subluxations getting out of bed. He says he can't participate and he wants to play football and baseball. We have a new study, a new MRI scan. Let's see if I can slow it down. A new MRI scan here. And I'm just going to try and show you what I see here. You can see anchors in the front of the glenoid, but perhaps recurrence of the tearing. What I'm trying to show you in the middle image is that he does not have a Hegel tear. And Nitin, let's stay with you. You can see the 3 suture anchors placed along the anterior inferior glenoid. Are the anchors placed poorly? What did we do wrong for this guy?
No, surgically, the position of anchor seems to be adequate and it seems to be a good repair. Even just the end face glenoid width also seems to be adequate, although you would like to make some measurements of the width of the glenoid and also the width of the Hill-Sachs defect to see if it is on track, off track. But no, surgically the repair seems to be good.
So now what do you tell him?
Paul, in the first situation, was that slap okay? Or was there any posterior lateral tear which was missed? Or how much was the Hill-Sachs on the first time, which you have not mentioned?
So at the initial operation, his posterior and superior labrum were completely perfect. And he had a very small, not deep Hill-Sachs lesion. So I'll give you more information because this one I'm going to slowly dole out the information. Here is his CAT scan. So in his CAT scan, what I'm trying to demonstrate to you is that he has, at least on the CAT scan, a more significant Hill-Sachs, but no bone loss. So this is a boy, he's 18. He's had what we think is a reasonable first-time arthroscopic surgery. In a relatively short window of time, he's failed. He's now gone on to feel instability at low-level activities, not even at just sport. Dr. Desai, I come back to you. Yeah. He wants some sort of revision surgery. What are you going to do for him in a no bone loss?
Okay, 2 things, Paul. Number one, Would you be able to tell me the status of his ligament? Generalized ligament laxity or collagen. Is he bad?
You know, I think he's not bad, but he's not normal.
Okay. So now that means he might be my GLL 3 or 4 and my capsule type 3 or 4. That's number one I'm going to assess. Number two, I don't think this Bankart repair has healed. It's a well-done Bankart, but it hasn't healed. And I see from the CT scan that the gentleman who did that probably did not create an interface which will allow the healing to happen. How do you expect the soft tissue to heal to the cartilage when we know that soft tissue to bone healing is a challenge for the last 50 years? And that's what I keep saying. This is not healed. And it has given way, is not big surprise to me. So I will go down again. I will not be tempted to do a lethargy, but I will counsel the patient. I will certainly educate him that you're not born for contact sports. I know your population is not going to swallow that, but at least I have done my job of informing my patient that you are constitutionally not designed. That bodybuilder I showed you in my slide, if he insists he wants to be a jockey, a tough luck. So I will inform this to the patient and then go ahead and do a revision arthroscopic Bankart repair and use all the tricks that I have to see that I enhance the potential for healing.
All right, so Sundar, we've got a first vote for arthroscopic repair. I'm going to give you a little more information. Each guy's going to get more information. Here's his examination under anesthesia. So his shoulder pops out and stays out, pops out and stays out. He has no significant bone loss. Sundar, now you're going to have the chance to vote on his operation with this information. No bone loss, maybe grade 3, depends on how you want to argue. We have one vote for revision arthroscopic. What do you say? What happens in your hospital?
I do the same. I put the scope and see inside first. I mean, either there is sometimes the second time injury can result in further injury to the whatever the labrum which was not healed, as Sanjay sir said. And there could be an associated injuries, could be I don't know, I'm not sure, but it could be some slap tear. As I said, the heel sac has progressed a bit compared to the first time, as you suggested too. So if in that case, I still go ahead do the repair again with the remplissage.
So now we've gone from revision arthroscopic plus remplissage. Nitin, I'm going to give you more information because again, you're in a good spot. So you have two looks. No. You have first is an arthroscopic appearance of his labrum. And as it turns out, I think that the Professor Desai is right. He doesn't seem like he healed, but wait, what was that thing? Hang on. I'm going to look down the front again. He hasn't healed very nicely, but the MRI really didn't depict this too well. Here now is his heel sacs. So it didn't show up that obvious on the MRI scan when you tried or the CT, but now he's got some unhealed anterior labrum and a pretty large heel sacs lesion. And he's 18, failed previous surgery, wants to play a collision sport. Do you dissent from the first two doctors, or are you going to go in a scope again?
Okay, so my take on this, somebody who's as young as it and has had a reasonably good repair and has failed, wants to get back to sport again, my first choice would be a lateral procedure for him. He has got a mid-level instability rather than an end-level instability, wherein it's dislocating very easily. So he does not even have the negative compression or the concavity compression effect, which is working for him. So mid-level instability is something which I would like to treat with a lateral procedure. That's also going to address the issue of off-track issue, because you're going to convert an off-track into an on-track. But at the same time, as Dr. Sanjay rightly said, I would try to counsel him out of a contact sport, because in spite of doing a lateral J, it is going to reduce his instability, yes, but with his sport, which is extreme external rotation, I'm worried about the large heel sacs. That's why I would probably try to discourage him from the same sport.
Okay, Anand Murthi, You now have 2 arthroscopics and 1 ladder J, because there's only 2 operations. There's only arthroscopic plus and ladder J. Can you please settle the tie for us? Does Nitin have to go to the beach in Goa and relax, or are the guys in Bombay right? What is your answer to this surgery?
So you're only giving me 2 choices, or I get to give you my choice?
I know your answer at this point. I'm trying to bait you.
Good. So my choice would be, I think he didn't heal his labrum. He has this moderate size Hill-Sachs defect, which is not uncommon. So I would do an open capsular shift, Bankart capsular shift, render that Hill-Sachs essentially extra capsular. And then most likely if he's stable, then we're good. If not, if I feel he has any potential for redislocation or that Hill-Sachs is too big, then I would probably add a long head biceps transfer.
A what?
Like that, didn't you?
You're gonna do say again in English.
A long head biceps dynamic anterior stabilization.
Anyone? Nitin, Sundar, do you trust this guy? Long head biceps transfer. It's the short head. Anand, if you read the papers on ladder J, it was the short head that was transferred.
No, it's the long head that's transferred.
May I comment?
That's what I'm transferring. Yeah.
I'm with him. What he says. Mark from Germany has been doing a study on that. The way Latarjet works essentially is retaining the lower third of the subscap. You don't need the bone there. So you can do a biceps tenodesis on the neck of the glenoid is what he's saying, I guess. And that will do the job of retaining the lower half subscap.
So Sanjay, if you have to be the judge, which is going to give someone more predictable external rotation? Is Nitin's ladder J or is Anand's open capsule shift with augmentation of long head biceps, which is more likely to restore external rotation so that he can bowl or throw again?
I can't, honestly, I can't answer that because I don't have much experience with the biceps technique. But I'm very doubtful whether this patient will be able to go back to that same level of sports, no matter what you do.
I think that's fair. Sundar, do you have an opinion on who you're going to support now? Do you support Nitin or Anand?
No, I'm going to support, as already Sanjay said, this patient has a vulnerability of dislocation again. So I still do with, because this Hill-Sachs is not very deep and he didn't have a frequent dislocation. This is also a second time an injury, but I don't know the exact detail of the second time dislocation. But still I would do a revision Bankart repair with a 2 anchor remplissage repair and counsel him about the chances of failure.
Okay.
I don't do a non-anatomical procedure in this case.
Nitin, now that you've heard everyone talk, you want to weigh your final opinion?
Yeah. So my main issue is yes, revision arthroscopic Bankart and extra capsular placation along with remplissage is going to reduce his recurrence rate, but it's definitely going to make him more stiff. And I don't think he'll get back his external rotation that's required for his sport. That's a definite thing for him. So that's something I'll talk to the patient. Whereas a Latarjet procedure is going to give him that stability, and also he's going to get that required external rotation required for sport. He has got a small risk of a failure of a Latarjet if he goes back to sport, but that risk of failure is small. And I would tend to go towards a Latarjet, which is going to retain his movement, which is going to reduce his dislocation rate, because your Latarjet is not just the bony, as Dr. Sanjay said. There's a lot of soft tissue component. You're buttressing the subscapularis down, and you have the sling effect of the conjoint tendon. So I think the stability is much more with the Latarjet, and that's what I'll be sticking on to.
Well, the survey says he had ladder J operation. I chickened out. I was very worried about every single part of this. I was very worried about his Hill-Sachs. He did not return back to an easy course. It took him about 7 months to be able to throw again. But after about 7 months, he started throwing again. And I had very few Latarjets in throwers. You know, in my hockey and football and American lacrosse, I really don't worry because their arm doesn't get into that sort of provocative position. But in the thrower, I felt it was a reasonable choice. He did feel his Hill-Sachs lesion, I think, as he got into a very provocative position. So that's what I chose in this case. Anyone on the panel or any other comments? You know, in the interest of time, I think I might hand it over because we're at 10:50 and
Paul, one question, if you allow me, only one question.
Yes, you're allowed.
Paul, if you were allowed to rewind in time, and would you do this primary bank cart repair and curate the cartilage and make sure that it heals?
So I'm 100% sure, and I think I've told you even before your article, I saw you curate the cartilage, and I think that's an essential component. And I think what you say about getting it to heal has got to be a major issue. So yes, I would like to. I think what I don't know is would I have done a remplissage in the thrower? I'll do it in a lot of my collision athletes, primarily in the first.
And you would have done after the first dislocation, right?
Every year that I get more gray hair or less hair, I'm more encouraged to operate earlier. But it's very hard for the in-season athlete, and you know, they'll go run to the second opinion who will say you don't have to operate. So I believe that you're right though, because the more they would let them come out, the more damage that they're going to have at the end.
Thank you.
Dr. Joseph asked a question, just sort of looking at the panel. Do we repair the capsule and the labrum after Latarjet? Personally, I do not repair the labrum. I will sometimes sew the capsule to the bone block, but more and more, I actually remove the CA ligament because I think I can get a better, closer fit. And I think the CA ligament can sometimes obscure my being flush or a millimeter recess, not more than that. But I wouldn't mind the other panelists to respond to Dr. Joseph's question. Do we repair the capsule and the labrum after Latarjet?
Okay, Dr. Joseph, I repair the capsule back to the CA ligament stump.
I do the same. I do the repair of the medial capsule to the CA ligament.
The panel also wants to know, let's start with you at the top. Do you use mattress or simple sutures?
I do use the simple stitches.
Me too, unless I have a bony bank cart where I'm repairing, and then I don't use simple sutures.
Okay. Well, listen, I think we could go for a long time, but I have the fortune of introducing my colleague, Dr. Uma from Johns Hopkins, and he's going to take us into the third and final section of our group.
Thanks, Paul. Yeah, switching gears here, we're going to talk about proximal humerus fractures and when to operate and what our algorithm is to sort all of this out. So really the problem is, if you look into the literature, as we've kind of been doing all evening, you're left with less than satisfactory answers. There's quite a bit of literature that's out on the topic, over 4,000 papers. But when you look at it, there's such a variety of problems in terms of the type of fractures that we see, varus and valgus, angulated fracture fragments, different kinds of patterns, classifications that we don't fully agree on or aren't very reliable. We have so many different techniques of what we can do for this fracture pattern, or for all the different fracture patterns. Our patients are quite diverse. Some are quite elderly, some just very demanding or very active. And then even our own experience as surgeons is quite different in terms of our experience and training and what we're comfortable with. And then finally, even geographic variations in our healthcare environment. So this world literature that we try to look for answers is really a blend of a lot of these different issues. And that often leads to something, not particularly, appetizing and hard to sort out. So what do we really use is, what are these main factors that we consider to decide? Of course, the first is our patient and what they are interested in achieving and their goals and their background, but also the fracture itself and the pattern and unique radiographic findings, what we bring to the table as surgeons, and again, our healthcare environment. So it's really just a complex interplay between all of these factors and a shared decision-making in the end as we try to match up these, what everyone really brings to the table. So first, starting with the patient, of course, we consider things like age, but more than that, their demands and activities, what they're interested in doing both for work or leisure. Their handedness may come into play, their overall health, comorbidities, their social support at home, things like smoking history, their own risk tolerance, and what their expectations are for the surgery and for long-term activity. And when we look at a fracture, of course, we're considering things like the tuberosities, their positions in particular, relative to the head and the shaft, the degree of displacement or angulation. And sometimes we can try to estimate the level of vascular compromise and how that might affect our treatment choices. And finally, bone quality of the patient that we're dealing with. With respect to the surgeon, our training comes into play, whether we're from a more trauma-based background or a shoulder arthroplasty background, may generate some bias within ourselves of how we propose different solutions, our overall experience and what technology we have experience with and what we're comfortable with, and what we can make successful on a consistent basis. And then even the healthcare environment these days, there's so much variation in what we're able to do in terms of the technologies that are available, whether our payers or governments are willing to pay for those technologies, and even cultural expectations and tolerance of deficits in function. So putting all this together, the algorithm that I typically use, first starting with the fracture pattern and patient factors, we often just ask how displaced and look to see how displaced this fracture is. If it's not clearly these non-displaced fractures, that's clearly a non-operative approach. And when we talk about the degree of displacement, if it is, even in that situation, in a low functional demand individual or a poor medical candidate or minimal pain, we're also going back to a non-operative approach. And what do we mean by a non-operative approach? Generally, a short period of immobilization in a sling, some early range of motion as tolerated, some gentle stretching to fight the stiffness that we see regardless of the treatment choice, and then late stage strengthening after that. So this would be an example of a minimally displaced fracture that I think all of us would agree that clearly appropriate for a non-operative care. So how do we get to the operative side of this equation? What types of things or what factors do we see with respect to fracture pattern or patient factors? So tuberosity displacement is probably one of the biggest ones, and greater than 5 millimeters, some have suggested that's a good indication for operative intervention, or large varus or valgus displacement. And varus is known to be worse than valgus, or substantial shaft displacement. Sometimes you can even see the shaft penetrating subcutaneously and causing pain and problems with that apex in the anterior position, or significant articular surface displacement of the head. So another way to get to the operative side of treatment is if the non-operative approach is just not well tolerated by the patient. So there's either ongoing unmanaged pain, worsening displacement, or just overall patient dissatisfaction. That's another way that we end up operatively treating some of these fractures. So for example, this 82-year-old gentleman with the fall on the stairs, significant medical issues, initially treated with a sling and physical therapy. But as we follow this individual, the fracture pattern kind of falling into varus, not happy with it. So ultimately revised into a reverse in his case. So as we speak of the operative side of things, how do we sort out all the different options that we have? And again, considering these patient factors in a high functional demand individual, not necessarily chronologic age, but someone with high demands, either occupation or sport or leisure activities, and with high quality bone, good bone supply, nothing indicating on radiographs that would suggest a high risk for AVN, that would lend itself to internal fixation. And that includes, of course, a wide variety of different strategies, whether percutaneous pinning, nails, locking plates, fibular struts, newer technologies such as a cage, or other additional augmenting things, cement, to achieve our final reduction and union. If we don't have these things in terms of demand levels or high quality bone, we're thinking more arthroplasty type interventions. And if we look at the trends, at least in the United States, there's quite a bit of geographic variation, and you see these fractures being treated less than 5% of the time, all the way to over 40% of the time, the darker green areas in our countries. So there's quite a bit of variability, but overall about 12 to 15% of proximal humerus fractures are treated operatively. And we see the trends of decreasing hemiarthroplasties, increasing reverse shoulder arthroplasty, and fairly consistent levels of open reduction, internal fixation. So overall, again, 85% fall on this non-operative side and 15% on the operative side. And if you looked at all these different studies, for good reason, a lot of the results are quite similar, clinically speaking, from both non-operative and surgical intervention. So how do you, sorting out who gets what is the difficult thing. So from internal fixation, and where do you go from there if that doesn't work out? If one of those strategies fails, or there's some symptomatic avascular necrosis, that would also push you back into the arthroplasty part of this algorithm. And then again, we can consider two populations, again, patient factors as we're considering here, hemiarthroplasty or reverse total shoulder arthroplasty. The younger folks with disrupted blood supplies, and if you can get good tuberosity fixation, we're definitely leaning towards a hemiarthroplasty versus our older individuals with lower demand that are osteoporotic or with baseline rotator cuff pathology would be reasonably treated with a reverse shoulder arthroplasty. And even in the hemiarthroplasty case, if you're not able to achieve good tuberosity fixation, those may also get converted to reverse arthroplasty. So when you look specifically comparing hemiarthroplasty versus reverse arthroplasty, it is notably better, the reverse is, than hemi in almost all outcomes except external rotation in some studies. So in terms of improved motion and consistent and reliable outcomes, the reason for the trends towards RTSA are warranted. So another consideration we mentioned was the issue of vascular compromise and where that comes into this algorithm at various stages during our consideration for the operative treatment and whether an internal fixation or arthroplasty is appropriate. So the classic Hertel article looking at the positive predictive value of ischemia based on this anatomic neck fracture, the short calcar, the less than 8 millimeters of displacement, or disrupted medial hinge that is talked about. And this article is quite interesting. Another article that came out after it did not find the same ability or reliability of that of those criteria to predict it. So in my experience, it's very hard to predict that even with those criteria ahead of time. So the vascular compromise issue based on imaging findings, I don't really use much in the algorithm to figure out what to do, and again, lean heavily on these patient-related factors. So now considering the surgeon and the healthcare environment, really the question here is if you are a high volume ORIF surgeon or an arthroplasty surgeon, or if you have these different technologies available to you. And if it's yes, I mean, you have the whole spectrum available to you that you can work through this algorithm. But if it's not, it's completely appropriate to refer to a higher volume center, and educating your patient about that option is probably a good idea as well. As we've seen, there's quite a bit of data in general about surgeon volume, center volume, and experience both with clinical outcomes as well as improvements in cost outcomes with higher volume places, as well as lower complications. So overall, this is the algorithm that I primarily use to sort some of these out. And again, most of these are treated non-operatively. But in terms of where we can go, I think some better trials that are more specific to the fracture pattern and patient types that are sort of less heterogeneous, that will improve our ability to sort out who should have which treatment. So this would be an example that published their criteria. They're very tight criteria of just 3-4 part fractures in a group that's over 60 with one technology, a locking plate. So it'll be interesting to see some of these studies come out in a multi-center fashion to help further guide us. So overall, of course, you have to consider all these factors, and most importantly, I think the patient, their demands and expectations and what they're trying to achieve and their tolerance for risk of the surgeries. It's it.
That was an excellent talk, Uma. Thank you very much. Anand, I think you can now share screen and take us through you and Shri, who I guess I'll have you introduce in a moment too.
Excellent. Thanks again, Paul. And this has been a great evening of discussion. It's been really, I feel privileged and fortunate to contribute. So we're going to do some cases to finish off the night. I have my young co-moderator, Sri Pinna. Are you on? Can you hear me? I see you on here. Unmute your device, your Zoom device. And then our panelists are, you're on here, Sri?
Yeah, I'm on here. Thank you for having me.
Perfect. And we have our panelists, Dr. Maheshwari and Dr. Reddy. Excellent. So we're going to go through these cases. We're going to alternate a little bit, and I'll ask the panelists some questions on what they'd like to do, and we'll finish up the night. So these are all the cases that Paul sends from Connecticut as he feels inadequate to try and fix these. They're not little arthroscopic bank art cases. So this is a 48-year-old male, fell down the stairs. He does smoke. You can see his fracture pattern here. Dr. Maheshwari, what would you do in this case? What are our options? Please describe what you see and what our plan will be. And I'll go back and I'll show you as you talk to us about that.
Yeah, I think it looks a fairly badly displaced fracture in a 48-year-old. I would be inclined to fix it. And looking at that there are tuberosity fragments there, my choice would be plating.
Any additional equipment you would want to have in your operating room?
Not in a 40-year-old, but in an older patient, I may keep some kind of a bone graft or a bone substitution ready.
Okay. Dr. Reddy, how about yourself?
Yeah, it's an interesting fracture because if you look at the head fragment, the lesser tuberosity is attached to the head, and that's actually rotating the head downwards and backwards. So that's one important point you should pick up from that CT scan. And there is a reasonable chunk of the greater tuberosity. So I would definitely go for a open reduction internal fixation, delta pectoral approach, get the subscapularis, reduce the fracture and stabilize. I don't tend to use any supplements of bone or bone substitutes in these fractures. And getting the sutures in the right place and getting the head in the right place is more important.
Can you mentioned something that I think is really important. Can you talk to us about suture management or how you utilize sutures in this case?
I start all my proximal humerus fractures with sutures on the subscap first, then on the supraspinatus, then on the infraspinatus. That gives me the hold on the fragments, one. Secondly, in this particular fracture, if you look at the rotation of the head, you cannot derotate that head unless you hold the subscap and pull it towards yourself so that you actually derotate the head. Once the head is derotated, then you can get your medial calcar aligned, and then you place your greater tuberosity back onto the fractures.
Excellent. Dr. Maheshwari, how do you set up this patient in your operating room? Beach chair and OSI, radiolucent table, fluoroscopy.
Yeah, so I do them on a beach chair position, and the image intensifier comes from the head side, so that intraoperatively I can do a good AP and a axillary without moving the shoulder itself. And if tuberosity reconstruction is a important issue, which it is in this case, where the head is quite okay, I would actually go from anterolateral approach rather than delta pectoral.
Oh, we have an antro, so a splitting approach.
Yeah.
So we have one. What do you think about that, Dr. Reddy? What do you think about the deltoid split?
I'm more comfortable with the delta pectoral, so I'd go delta pectoral. So.
I'm a little with you. Maybe I'm just not good enough getting exposure that way. So this is what we did. It was a pretty displaced fracture, obviously, huge canal, and we also added our typical suture augmentation. I start just like you said yourself, getting fixation into the posterior cuff, the subscap, the tuberosities to gain control of the head. And this is obviously a high energy injury. We utilized a plate through a deltopectoral approach. I do use struts. In this case, it was because I think usually of the high energy, there's significant comminution at the neck, and we used some dowels. I use often distal ulna, as the flare will actually keep the head from falling into varus. So the distal ulna works very well, and any kind of bone substitute to keep the head from falling into varus, and obviously getting your calcar screw as low as possible. Key things in the OR, especially having great fluoroscopy, check your images before you start the case, making sure your fluoroscopy can give you great visualization. And this is the final product.
Can I
go ahead.
An interesting observation in the last one, he was only 49, but his the cortex is very thin.
Right. I think he's a smoker. You know, he probably also has some alcoholism on board too, maybe giving him some thinness, poor nutrition. But fortunately, we were able to get him to heal this fracture. So I do use struts. Occasionally I have them in the room for they help in the reduction as well as the stability. And I think just having that option available, especially in high comminution, high energy fractures, more commonly in the elderly patient, has been useful for me for ORIF.
So may I make a point, since it is a East-West, meeting, I understand in the West you have allograft availability. So
yes,
the morbidity of taking the graft out is not there. That being an important consideration in our country, a lot of us are quite reluctant to take a graft even wherever it is required. I've learned the hard way, and I think my threshold for taking out the graft, even a autograft, has actually gone down after having had a few failures. So my message to my younger colleagues who are watching from India, do not hesitate to take additional graft, because a lot of these fractures have a lot of bone vacuum, and just fixation cannot help it.
And one observation from the Indian perspective again is that I've used artificial bone in this once, and I've regretted it. I'm never going to use again because the wound was leaking forever.
Right, I agree. If there's some of the grafts, especially the man-mades, can create a seroma. We actually will use on these high energy cases. Often we'll use an incisional wound vacuum sponge to actually help keep the swelling down as too. That's a nice adjunct after the case is over and helps the incision heal nicely. So I am going to hand this over to Sri for the second case. So I'm going to stop sharing. Sri, are you ready?
Yep.
Excellent. You're up.
Anand, can I ask a quick question?
Of course. I did not use a curette on this case.
You're a wise guy.
Never use a curette.
Did this fracture heal, and what was the eventual function like?
It healed. It took him about 4 months. We started his range of motion pretty slowly because I didn't like his cortices were kind of comminuted. So we keep him in an external rotation brace to prevent stiffness for about 4 weeks. We start active assisted and passive at that point, follow him radiographically, and started his strengthening around 8-10 weeks after surgery.
You guys see this okay?
Yep.
Okay. Thank you for having me on this panel. So I gave Anand 7 or 8 cases for me to pick from, and he had me pick my most complicated ones. So we'll see how this goes here. So the first one is a 64-year-old male, fell downstairs, taken to the emergency room, noted to have a proximal humerus fracture. The emergency room placed him in a sling, had him follow up with us in the office. He has a history of alcohol use, major cardiac history, open heart surgery, history of chronic MRSA infection that he's on antibiotics for. And he actually comes into my office 3 weeks from the date of injury. And so he actually has minimal pain. And he comes into my office, no sling, with this fracture pattern. So right out of the gate here, I think most people would agree that this is an operative fracture. Would everyone consider doing a ORIF versus anyone doing closed reduction pinning for this type of fracture 3 weeks out?
No, open reduction.
I would do a nailing in this.
Oh, I like Dr. Maheshwari's mind. I love it. How about Dr. Reddy? What do you think?
Yeah, I would prefer intermediary device for this one too.
Two. We've got two. I agree. I would go for a nail as well.
Okay.
Sri, do you agree with us? Are you against your three elders?
I clearly did not do a nail. So, you know, he was a 64-year-old small guy. He's unhealthy and he is unreliable. A nail is definitely probably a very good option for him, but I felt like in my hands, I do a proximal humerus fracture mostly with plates and screws. So that's what I did. And so I took him to the OR the following day to do a ORIF, the proximal humerus, and I was able to get this reduced pretty well. So let
me ask you a question, Sri, since you're early in practice. This was 3 weeks out?
Correct, yeah.
So one of the things I would tell you to be cautious of in a case like this with a sharp distal segment like that is that on a few occasions you can actually have it tamponading some of the medial vessels. And something that's 3 weeks out, that's scarred in, and then you go in and you reduce it, or if you try to reduce it pre-op, you can potentially get into some significant bleeding. So I would have just at least a vascular set there. Make sure you're not doing this in your outpatient surgery center. Because you can get into some bleeding on this case. Obviously, you probably didn't, but just something to think about.
Yeah, that's a good thought. I use TXA on all my open cases, and he was 3 weeks out. We were able to get a pretty good reduction, a pretty good calcar reduction. My approach is similar to what was described earlier, where I tag the subscap, supra, infra. What about the biceps? What do the panelists do with the biceps? Do they leave it intact? Do they do a tenodesis? Is there any role of a tenodesis?
So if you have a fracture like this, now if you look at the alignment of the proximal fragment and the distal fragment, it's quite distant, and there is a sharp distal fragment too. So there is a very high chance that the biceps is torn or even, destroyed. So in those situations, I just tenodesis it to the pec major. Whereas if you have a continuous sleeve, which is around the biceps, right from the shaft onto the head, I leave it alone. I used to do tenodesis routinely, but now I've moved away from it.
Yeah, so that was my thought as well. It's with this much displacement and with the shaft being so anterior, I felt like I needed to release the pec from pulling it anteriorly. So kind of killed both two birds with one stone. So I did an ORIF. I used this plate. I was pretty happy with the reduction. Felt pretty good with my with the intraoperative findings. Any critiques on the X-rays?
Yes. One, the reduction is good. So that's a good starting point. You said you use sutures, and that's a good thing. The only critique I had was the length of the screws. They look quite long for a proximal humerus fixation.
And I would never comment on just a single X-ray.
Obviously, but
I like it.
looking at what you have, the image you have, that's what I mentioned.
Shri, may I comment?
Yes, of course.
There is a significant risk of this head falling into varus and your plate cutting through.
I think a couple things. I think it looks pretty good, especially if you're using suture fixation. perfection, you probably want those Calcar screws a little bit lower. And like you said, we often look at fractures when we're using imagery and fluoroscopy and kind of this AP. The AP looks great, but you also got to make sure the version is good too. They should be in some relative retroversion. When you look at your axillary, you don't want to be anaverted. And also, my question to you now is how did you rehab this person with this kind of bone quality?
Yeah, post-op with him being unreliable, I really locked him up for the first 2 weeks. And so I usually see these type of patients at 2 weeks, keep them in a sling, and really limit them outside of distal range of motion to the wrist and elbow. And so I had this patient follow up with me in 10 to 14 days. However, he didn't show up to his post-operative visit. And he actually showed up 4 weeks after his surgery and with no sling, was not compliant with his weight bearing. And he shows up with and notes a deformity to his arm, but still has no pain. He presents with this x-ray. And so, like we kind of alluded to, I probably could have placed a bigger plate or used an intramedullary fixation to help prevent residual displacement. But this is about 4 weeks out. But there's already this callus formation. But this is I feel like this is a very interesting way for this fracture to fail. Is the screws in the head were intact, but it just pulled out of the shaft.
Do any of the panelists have any worry that he continues to not have any pain after these injuries?
Sorry, just repeat the question.
Do you wonder why or worry about why he had never had any pain, even with that initial displaced fracture, and now he's like this and he still doesn't have any pain?
Yeah, there are two important things to look at in this image. That one is the head is subluxed inferiorly, so I don't know how much the deltoid is really functioning. So there is a neurological component to this injury too.
Yeah, I wonder if he has some type of neurological, he's an alcoholic, Charcot, he's not having proprioception, no pain. Yeah, it's interesting. I'm sure Sri's going to finish. What do you think? What's the story?
Yeah, so I saw him at the 4 week point, and really at this point, my treatment options for him included a revision ORIF. And so really here, my decision points were either converting this to an intramedullary nail versus doing an ORIF with repeat plate fixation.
Hey, Umar, are you on? Umar, are you still on?
Yeah, I'm here.
What do you think?
What would I do at this stage? I actually agree with Sri. I don't think I'm a plate fan, so I probably would have treated this the same with a plate, maybe, with hindsight, a longer plate, more distal fixation. But I think your point of why is he having no pain is important. Does he have some cervical spine issue or some neuropathic issue to work up as well at this stage? Or is this all sort of alcoholism related problem? So with the revision surgery, I would definitely bring in some allograft and bone grafting techniques to really enhance the fixation. I really hate nails, so I would just never use them.
Now, if he's painless, can I come in?
Yes. I was just asked you, what would you do?
Okay, so if he's painless and I can see some bridging callus forming there, and if patient actually has no pain and, I can examine clinically and find there's no any mobility there, I might be tempted to just wait and watch, and it might just heal him.
That might be a good idea.
That's an option because he has MRSA and other history and everything else too. So.
Yeah, I ended up taking it back to the OR, and so I actually took him back to the OR and I did a big revision surgery. So I actually took these distal screws out, re-reduced it to the plate, the humeral shaft, and then placed those screws back in, and then actually used this long anteriorly based plate to kind of cover the calcar. I augmented with cadaver graft, structural bone graft with a small strut, distal ulna actually, and also some cortical chips.
How are they doing?
So this is about 5 months out. I took him very easy. I basically made him non-weight bearing, sling at all times, and really locked him up. And this time he was actually compliant and showed up to his post-operative visit, laid the crepe with him. And at the 5-month point, he's doing pretty well. He like we commented earlier, he was a little inferior sublux, probably from some deltoid atony, axillary nerve, neuropraxic type injury. But that did slowly resolve over the 3 months after surgery. And at 5 months, which is where he is at right now, there's a little backing out of one of the distal screws, but outside of that, overall pretty well healed, clinically doing well, obviously no pain. And then forward flexion to 90 degrees, abduction to 90 degrees, introduction lumbar back. So we'll have to see how he does in the long term, but for right now, everything looks okay.
Nice job. It's a metal sandwich, tasty metal sandwich. Hey, Paul, do we have time for one more?
One more, yes, sir.
All right. All right, Sri, stop your sharing, and I'm gonna share it. All right.
Okay.
All right. Let's go a little younger and a little healthier now. Can you see this, Paul? Are we good?
Confirmed.
All right. So this is a 22-year-old healthy female snowboarder. Came in a couple days from the slopes. This is the fracture pattern you see. 22, super healthy, very active, works, doesn't smoke. Dr. Reddy, what do you think? I know they don't have too much snowboarding in India, but
no. Yeah, it's a varus fracture, which is essentially a two-part, one displaced, and the distal fragment jetting out through the deltoid laterally. And this
you can actually feel it. You can actually feel that piece. She's skinny.
Yes, and that's usually the case, and that's why these sometimes don't heal if you go for a simple non-operative treatment. So that's one of the reasons why you go for surgical intervention in this. And already there is a rent in the deltoid already, so I would actually think of a nail with a deltoid split.
Excellent. Dr. Maheshwari?
In my practice, she will go for a percutaneous fixation. Particularly because a lot of these girls are very cosmetically conscious. So it's a good fracture, 22-year-old female, not much comminution. I just pull it straight in the OR and put percutaneous fixation.
When you say percutaneous, do you mean pins out the skin, cannulated screws? Okay, pins out the skin.
Yeah,
okay.
pins out of the skin.
And when do you remove those usually?
Usually 3 to 4 weeks.
3 to 4 weeks. And then therapy after that?
Yes.
All right, excellent. Sri, how about you? Double plate sandwich? Double plate sandwich?
Put more metal in there, the less you see the fracture. No, I would use a plate, and this looks like a simple 2-part fracture, some medial comminution. I think in an older patient, in my hands, and someone that's 50 or older, I would think about doing a nail because that medial comminution is something that I get worried about causing some varus collapse with a plate. But in my hands, 22-year-old, good bone quality, I would do a plate and screw with suture augmentation.
So we talked about these options: perc pinning, plate. So this is
observation again. Can I just interject? In these fractures, when you look at it, especially, you should be very careful because there is a degree of retroversion and the head actually falls backwards. Getting a control on that is difficult when you go percutaneous. And AP view and your lateral view sometimes are not as helpful when you are looking at the rotational component of the head, humeral head.
Exactly. Thank you. So we ended up doing a nice, we did a percutaneous reduction with this little pushing clamp, and we have to get certain radiographic views that we get fluoroscopically. And our plan was to nail this with the proximal compression nail, and it actually ends up going percutaneously through the muscle, medial to the muscle tendon junction. It's a straight nail, so as long as you get these great views, you can actually get a really nice percutaneous technique. So this is done through, I think we had about 4 almost arthroscopic portal type incisions. This is 5 weeks post-op. You can see the nails buried. There's no prominence. You can actually, the screws compress into the nail, so you're not worried about even in older patients pulling out in soft bone. This is at 5 weeks. I don't move them because there's not much scarring that occurs. And this is at 6 months. She had a very good result back snowboarding. Cosmetically, very nice. It's like having an arthroscopy. So another technique, I'm glad we got to show this one as well. Paul, I think I'm done. If you want to take over, thank you, everybody. I appreciate it.
Awesome.
Wonderful.
Hey, guys, I just want to say thank you to everyone. This is, of course, as usual, a great meeting. It's our 3rd virtual meeting, and just thank you to Shreyash for working so tirelessly to get the agenda and the speakers from the Indian side with Paul and Mandeep. It's just been phenomenal to sit and listen, and I just learned so much. The vast experience that you all have in India with these topics is just impressive. Dr. Desai, I don't think I can live 3 lifetimes and do 3,500 bank cards. So learning from you is just taking us leaps and bounds forward in terms of our ability to care for our patients here in the U.S. And on our side here, thanks to all of our speakers, including our youngest speaker, Sri. He was a little under fire there by Anand there, but everything was so much fun and so good. And it was also great to see my old buddy Clem Joseph, who when I went to India 12 or 13 years ago, was a fellow with Dr. David Rajan, and now he's speaking to us, and we're learning so much. So it's just great to see the collaboration back and forth. And I hope that sometime in the next year or two, we can do this in person and really make it a fun time of it. So thank you all for participating, and I really appreciate from the bottom of my heart everyone spending their day and night with us for this night.
Samir, can I just chip in with a word of thanks to all of you guys? Samir, Paul, thank you for organizing this. To all the great US faculties, Uma is quiet but very effective. Mandeep, again, excellent lecture. Anand, good to meet you today, and great to know that you share a good camaraderie because you have defended Sri as well in your case presentation. So great. And Sri, keep up the good work. We're all learning, so fantastic to have you. And importantly, I'd like to thank my Indian colleagues, Dr. Maheshwari, Dr. Desai, Dr. Prateek Gupta, Dr. Deepthi, Dr. Sundararajan, Dr. Clement Joseph, and Dr. Nitin for being part of this meeting. And we look forward to future collaborations and learning from each other. Thanks a lot.
Absolutely. Thank you all.
Thank you. Thank you.
Thank you, guys. Thank you. Take care.
Thank
Bye.
you. Thank you. Bye-bye. Thank you.